And hello everyone, and welcome back to our fertility Q&A live with Dr. Scott Roseff of IVFMD tonight. We are going to be joining him shortly, and my name is Fertility. For those of you who don't know me, I'm a licensed reproductive acupuncturist here in Miami, and we are going to be taking your questions tonight on Facebook, Instagram, and YouTube. So we're going to wait for Dr. Roseff to join us. He should be coming into our little Instagram live shortly. And just so you guys know, you can feel free to share this with your friends. If there is anybody you know, oh, there he is, who is struggling with fertility, we're here to help. So Dr. Roseff coming in, we're going to say hello to him. And I really appreciate him for being here today. So there you are. So hi, Dr. Roseff. Can you hear us okay?
I hear you okay. Can you hear me okay?
Yes, very good.
Great.
All right. So we received so many questions today. I was really thrilled to see everybody submitted like some very interesting things that we're going to talk about, having to do with fertility, having to do with the vaccine. Someone submitted some information and questions on that, and also questions on reproductive care, like preconception care prior to doing a medicated cycle, and all kinds of things. So we are going to try to get to all these questions tonight. And also I encourage you guys who are on right now on Instagram, Facebook, and YouTube to ask questions in the comments section. So we'll be able to to get through those questions when we can. So Dr. Roseff, if you could introduce yourself too, for those who don't know you on our Instagram, just let everybody know where you are.
My name is Dr. Scott Roseff. I'm a board-certified reproductive endocrinology infertility expert practicing out of Boca Raton, Florida. My practice is IVFMD, and we practice all aspects of reproductive medicine. So anything that anybody would need to either start a family or expand a family, we offer that in our practice. I've been in practice for 31 years. I practiced 17 years in New Jersey. I was the director and the founder of the Division of Reproductive Medicine at St. Barnabas Medical Center. And I had a private practice in New Jersey as well. And then I practiced in Wellington, Florida for about 6 years. And then about 9 years ago, I was recruited to join IVFMD. At the time, they wanted to build an office in Boca Raton, Florida, and I became their Boca Raton doctor.
Awesome.
Nice to meet you, everybody.
Very good. Awesome. So we are talking about two different perspectives, but really wanting to share the same goal, which is to help you have a healthy pregnancy. So those of you who are on Instagram currently, we are taking questions tonight, and we're going to also start with the questions that were submitted earlier. So we're going to go ahead and start reading those questions if you have them, Dr. Roseff, to start with. And then also feel free to type in your questions and to share this with your friends as well.
Does everyone know, for Dr. Duro, how to type in the questions?
Yes, sure. So just type in the comments below, and we will see them. And also, if for those of you on Facebook and YouTube, you can also type it in the chat, in the comment section. Yes.
So the first question that we received, and it's interesting to me because I've done these Instagram live chats before, and we also, our group IVFMD has Takeover Tuesday, where every Tuesday we have one of our doctors answering questions, and this question seems to come up quite a bit, similar to this. I had a retained placenta and a polyp removed through a procedure called hysteroscopy 4 months after vaginal delivery. There was an infection called endometritis on my first biopsy, and then second biopsy showed some very minor, and I'm interpreting this as I'm reading it, bits of infection. Now I'm on multiple antibiotics, metronidazole and cephalexin. Should I repeat the biopsy to ensure the infection called endometritis is gone? Is there a concern that this can flare up again, even though it was treated with antibiotics? So the second biopsy that this person had, when we do these biopsies, we do special testing of the inside of the uterus to look for infection. And there are certain circumstances where we suspect there may be an infection inside the uterus. After vaginal delivery or C-section, a structure called the placenta needs to come out. And if it doesn't come out, it's called retained placenta, which is what this person is asking about. And then that can necessitate surgical removal with a little telescope or a procedure called a DNC. Those procedures can leave an infection inside the uterus. And if we have an ongoing low-grade chronic infection inside the uterus, then that's an environment that's, of course, hostile for a subsequent pregnancy. If we have that infection, low-grade, mild, ongoing chronic infection, we don't get fever, we don't get chills, we don't get discharge, we don't get bleeding, we don't get pain. It's just there, and we don't know unless we do a test where we take a little piece from inside called a biopsy. So the biopsy showed infection, but the laboratory that does the analysis for infection looks at how much of an infection there is. And they actually count often how many cells, how many microscopic cells of infection they see. The first one found 15 plasma cells, which is a significant infection. And then there was a treatment, and the second biopsy showed 4 cells called plasma cells, which are indicative of infection. But it's very commonly believed that if we have less than 5 plasma cells, and the second biopsy here only showed 4, then we generally consider that to not be of any clinical significance. So whoever sent the question, your question is, do we have to repeat the biopsy to make sure the infection went away? This infection, apparently, according to your question, did go away. And is it likely to come back? And it's not likely to come back unless there's instrumentation or some kind of a procedure inside the uterus that subsequently predisposes to another infection. I hope that's pretty clear.
It does come up quite a bit. And it is shocking to see that, you know. How
many times one of my Instagram lives or one of my Takeover Tuesdays, I had question after question after question from different people about retained placenta and the effects of retained placenta. So evidently that happens on a fairly frequent basis.
Would you recommend they get an ultrasound after a DNC, like as a routine procedure? Because I know some people don't. No? Okay. So,
you mean to see if the retained tissue is gone? Oh, absolutely. Yeah. That would be, I thought you meant to determine infection, and we can't tell infection from ultrasound. But yes, if there's tissue inside the uterus and it's removed, then a subsequent ultrasound can't hurt to make sure that the uterine cavity looks clear.
Okay, so those of you who have had DNCs, you know that's a hard thing to go through. Make sure you follow up, you know, with whoever did the DNC to make sure everything's good. And so we do have a couple more questions actually, so we'll get to those too.
Another question that came in was, does a PGS normal embryo trump the embryo grade? Specifically, if an embryo is PGS normal, does the embryo grade still play a role in the success of implantation? So let's talk about PGS. PGS is a term that's no longer used, and it's an outdated for the last couple of years. We've replaced that term just to throw it out there. And it's not called pre-implantation genetic screening, PGS, anymore. It's called pre-implantation genetic testing for aneuploidy. It's a bigger mouthful. It's PGTA. Essentially what this is we get eggs, we get sperm, we fertilize the eggs, and we grow embryos. The embryos now have to grow in our IVF laboratory for 5 days or 6 days, sometimes even 7 days, to an advanced stage of growth and development called blastocyst. When the embryos are strong enough and advanced enough at the blastocyst stage, we take a microscopic piece called a biopsy off of each embryo, and we take that biopsy, the few cells that we remove, and we test those cells to see if they're genetically normal or not normal. The medical term for genetic normalcy or abnormalcy is aneuploidy. And so it's called pre-implantation because it's before we would implant the embryo into a uterus, genetic testing for aneuploidy, PGTA. And the question that someone sent in is, does a genetically normal embryo, is that more important than the grading of the embryo? So now we look at these embryos under the microscope in the IVF laboratory, and we ask ourselves, is this a nice looking embryo? Is it excellent looking? Is it good looking? Is it fair or is it poor? And that's grading of the embryo that's being asked about. And the medical term for that is morphology. So there are different parts of the embryo. There's the outer part and there's the inner part. And so we grade both parts, the part that becomes the baby and the part that becomes the placenta. And we give it A's and B's and C's and combinations thereof. And so the question is, essentially, what's more important, the embryo grade or the fact that it's genetically normal? It says if an embryo is genetically normal, does the grade still play a role in the process of implantation? And absolutely, positively, no question about it, the answer is yes. Because if you have a genetically normal, poor quality embryo, despite the fact that it's genetically normal and doesn't have things like Down syndrome, that poor quality embryo is not likely to implant, even though it's genetically normal. And if it does implant and it's genetically normal but poor quality, it's likely to miscarry. So embryo grading, embryo quality, embryo morphology is the single most important thing that we look at. So when we have these genetically normal embryos, let's say that we have 3 of them, we look at the grade. And if one is excellent grade and one is a good grade and the other is fair, then the excellent, top quality, genetically normal embryo is the one that we select to put into the uterus. Hope that answers that question.
Very interesting. Yes. Great.
We have some more questions that were sent in ahead of our live event. Do you want me to keep going?
Yes, yeah. You're doing a great job.
Great
moderating. Okay.
Someone asked, how long after giving birth should I wait to transfer baby number 2? So my guess is that means embryo transfer, which has the anticipation of successful pregnancy. After birth, if you're healthy and everything went well and there were no complications, you delivered a baby, how long do I have to wait to conceive again? Everything being okay, the answer is 6 months.
Okay.
The next question is for you, Dr. Duro, because I would not know the answer to the question. Is Moxa effective for fertility or fibroids?
Okay, so they're referring to moxibustion, and it's been used for thousands of years. It is part of traditional Chinese medicine. So it's a warming treatment. It involves one particular herb called, we call it aye or mugwort, actually. So you can use that for warming. We actually use infrared heat as well as sometimes we have a liquid solution of that herb that we use on the points themselves. But it is pretty pungent. So you can use the actual like non-smoking moxa at home if you'd like, if you don't want too strong of a smell. And those are usually the things that we use. But we honestly don't use it as much as other practices. We actually end up using it a little bit more during pregnancies. There's some research on breech pregnancies actually working with that and helping with, you know, fetal positioning. Yeah, that hopefully answers your question. Some people need it more than others, but we found that the acupuncture works pretty well without it as well.
The other part of the question was fibroids.
Oh, and fibroids, right? Not specifically. There are some practices that might use that, but I find that it takes a combination approach, and it depends on, I mean, usually we're not addressing anything over like 2 to 3 centimeters. They're really like more on the smaller edge with acupuncture, Chinese herbs, and diet, lifestyle tips, and and that sort of thing. So I don't think moxa alone would be as effective. You might be able to use that in combination with other modalities, like I mentioned, though.
Great, thank you.
Thanks.
Next question is: do we recommend a specific brand of myo-inositol, and is it better in a powder or in a pill? So I would anticipate that the question is in reference to polycystic ovarian syndrome, PCOS, which both Dr. Duro and I are experts in. And polycystic ovarian syndrome, for those who don't know, because this is pertaining to that, is a condition, it's the most common hormone imbalance in women of reproductive age. It affects about 1 in 10 women in the United States between the fertility years. It tends to be less of a problem after menopause. And with this hormone imbalance, we often have irregular menstrual periods. Polycystic ovarian syndrome often has excessive number of eggs growing at any moment in time. It also can be related, and usually is related, to excessive amounts of male hormone. And that can manifest itself in facial hair or acne or increased body hair. It predisposes to weight gain and obesity, and also some medical problems such as hypertension, high blood pressure, diabetes, type 2 diabetes, high cholesterol. And in pregnancy, it makes it harder to get pregnant. It increases the risk of miscarriage. And with a successful pregnancy, ongoing pregnancy, increases the risk of high blood pressure during pregnancy and gestational diabetes, pregnancy, elevated sugar. So polycystic ovarian syndrome, being common, is a problem that we both see in our practices essentially every day. I am, as a board-certified reproductive endocrinologist, I've done research on PCOS. I've published papers in peer-reviewed journals on PCOS. And I'm also nationally and internationally known for alternative and complementary therapies for PCOS. Example, I was invited this week for an invitation to go to Bulgaria in September of 2021, COVID permitting, to give a lecture about PCOS and the treatments that I use with inositols, these supplements. A couple of years ago, they flew me to Barcelona, to Spain, to give a lecture to the entire European Gynecology Society about polycystic ovarian syndrome and inositol, the treatment that I use for it, the supplement. And I was lectured in Rome. And in fact, this past March 2020, I published a paper in the International Journal of Endocrinology about polycystic ovarian syndrome and inositol. So I'm known as an authority on inositol, which is a supplement that we use to treat PCOS. There are 9 different types of inositol, but there are only 2 that are important clinically for treating women with PCOS. And not only do we need to use both of these, one is called myo-inositol that whoever sent the question in is asking about, but the other type is called D-chiro-inositol. And not only do we need to use both, not just myo-inositol, but also D-chiro-inositol, but they have to be in a particular ratio, which ends up being 40 times more of one versus the other. Mm-hmm. This 40-to-1 ratio of inositols is available through various vitamin companies and supplement companies. And the questioner asked, is it better in a pill? And pill implies tablet. There are no tablets for this that I'm aware of, but there are capsules and we have powder. I favor the powder over the capsule. So if you're going to do inositol, it needs to be the 40-to-1 ratio of myo to D-chiro-inositol, and I favor the powder over the capsule. If you're going to do it, it should be from a well-recognized brand, which I think is one of the questions coming up. What brand do you recommend? So I'll save that for a few minutes from now. Mm-hmm. Dr. Duro, is there anything you want to add to that, or do you want me to go on to the next question?
Yeah, I agree. Definitely it comes up, and there's benefits there's certain research that, we can talk about that has, melatonin with myo-inositol for women who are trying to get pregnant. I guess in stimulated cycles of PCOS, there's some favorable news about that too, helping with that. We use the powder as well. And so, there's Theralogics, there's many others. But I think Ovasitol is one that we've used. There might be others, but I have noticed that the ratios are different. So you have to pay attention to those for sure, whichever one you're getting. And
that was a very basic essence of the paper that I published last March. Had to do with, there were all these inositol type products on the market, and what's the truth, what's the science, and what do we really need? Because you're right, there's a lot of stuff out there. It's probably a multi-billion-dollar industry, the supplement industry, and there are a lot of people out there who just make a supplement just to make it and make $1, and you have to be really cautious with that. So check with your healthcare practitioner before you just buy inositol and make sure it's the right brand and the right combination. Yeah. The next question is inevitable, and it is, do you recommend the COVID vaccine if you're trying to conceive or if you're about to start the IVF process? So the COVID vaccines that were tested in the United Kingdom before approval for the United States were the messenger RNA vaccines from Pfizer and Moderna. Subsequently, after they were released in the United Kingdom, they were released for emergency use authorization in the United States. Vaccines, well, let me put it this way. Messenger RNA vaccines were discovered, I believe, believe it or not, 1969 was the first description of a messenger RNA vaccination and how to make it. The messenger RNA vaccines were used in animals starting in the early 1970s. So messenger RNA vaccines have actually been around for decades. It's my understanding, and I think it's a pretty good understanding, that until now, over the last several decades, that the messenger RNA vaccines were available for animal vaccination. We have never had messenger RNA vaccines available for human use. So we have this pandemic, and people are getting sick and people are dying from a virus. And so the clinical trials to determine if this was effective, these messenger RNA vaccines, and safe, were rushed to testing and rushed to the market for good reason. And the testing in the United States excluded women who were pregnant, so they were not tested on pregnant women. the women who were vaccinated and went into the clinical trials were told that they not only cannot be pregnant during these clinical trials, but they should not become pregnant within a certain period of time after the first and second subsequent vaccination. So the effect of the messenger RNA vaccines on fertility is unknown in both males and females. In fact, a very amazing colleague of mine in Miami, Dr. Ramasamy, who is a world-renowned expert in male fertility and the chief of male fertility at the University of Miami, has concerns about the possible negative impact of the COVID vaccination on sperm. And he's currently conducting clinical trials to look at the possible sperm effects of the COVID vaccination. For women, we don't know what, if any, impact the vaccination has on fertility. We don't know what impact it may have on pregnancy or subsequent pregnancy. And so the bottom line is you have to do your homework. You have to know that the risk is unknown. It's just unknown on fertility and pregnancy. And you consider getting the vaccination if the potential risk of infection with COVID outweighs the potential unknown risk of the vaccination on fertility and pregnancy.
Yeah, definitely. There's been a lot of confusion with that because everything is new. Everything's happening.
We get questions
so fast.
we get questions about the COVID vaccine daily in our practice.
Yeah, definitely. So that is awesome. So I'm glad that that question was brought up because I know we get that too. And we say defer to your primary care physician or your OBGYN and or reproductive specialist if you're going through IVF. So that means you're better, I guess, to delay right now if they are starting IVF or IUI soon, just to kind of summarize, or is it just depending on the situation?
I have patients who are frontline workers who are working in the ICUs with COVID patients, and their risk of COVID infection is high, and they are using PPE, personal protective equipment, to the max, and they have to decide for themselves. I cannot make that decision and will not make the decision for a patient because it's a big question mark. Will it have an effect on the eggs? Will it have an effect on the sperm? Will it have an effect on the embryos that are developed through our IVF program? Will it have an effect on a subsequent pregnancy? And it's a big question mark. Nobody knows. So every individual patient has to look at his or her risk of getting the infection and being hospitalized and being in the ICU and possibly dying. And if you look at deaths, there are deaths that currently may be attributable to the vaccine. There's an OBGYN doctor in Miami who was healthy and in his early to mid 50s and recently was vaccinated, and he subsequently died shortly thereafter. So the vaccine is not without potential risk. There are people who are getting Bell's palsy as a result of the vaccine, or potentially as a result because the FDA and the CDC, the people who oversee this, are not wanting to put cause and effect together. But people are having alleged adverse effects from the vaccine, including death. And if you think that you may get infected and or die with COVID, then you have to weigh that risk versus the potential benefit or risk of the vaccine. And honestly, I don't think I should be making that decision for my patients.
Right. So the research you said about male fertility, I saw some, Dr. Ramasamy was mentioning if they were infected with COVID, it had an adverse effect on the sperm health. But you're saying perhaps the vaccine they're not sure if the vaccine.
He has concerns about the vaccine as well.
Okay.
I mean, COVID, and again, I'm not an expert on COVID, but my understanding is that COVID this viral particle has spike proteins on it on the surface, and those spike proteins bind to angiotensin converting enzyme 2, ACE2 receptors on cells. We have ACE2 receptors on our cells in our lungs, and we have ACE2 receptors in the testicle, and there are ACE2 receptors in the placenta in pregnancy, and it goes on and on. And so whether it's the virus or the purpose, my understanding of the messenger RNA vaccine is to tell your own DNA to create spike proteins and then let your immune system attack the spike proteins so that you can build up immunity against the spike proteins. Well, if the messenger RNA vaccine tells your your ribosomes in your cells to create spike proteins for COVID, to me, a spike protein is a spike protein. And there are questions and there are concerns. And again, everything we do in the medical field is risk versus benefit. Mm-hmm. And every person has to do their homework, and they have to determine if their potential risk of getting COVID is greater than not, and they have to make a decision on the vaccine. And that's really all that I can say about it.
Yeah, and we'll know more as we get through this.
We'll know with time.
Yeah.
But
yeah.
It is the FDA, the Food and Drug Administration, that fast tracks this vaccine for emergency use, says we're going to see what happens to pregnant women and their babies and see how it turns out. And so that is a huge human experiment, and it remains to be seen if there is a negative impact. And we'll see. Time will tell.
Right. It's very hard
versus
to do a
a positive
trial.
impact.
Yeah, okay.
Right.
Yeah. So we'll keep moving.
The next question that came in is in Spanish. I can understand it, so I'm going to translate it, and I hope that the person who sent it in Spanish understands. If I try to answer it in Spanish, it'll be laughable, I think. So I'm going to do my best. In fact, I'm going to try to read it in Spanish, and then I'll translate it into English because I think I know what it says. It says, "Hola, buenos días. Si estoy embarazada, puedo tomar fluoxetina para la ansiedad," which is, "Hi, good day, hello. If I am pregnant, can I take fluoxetine for anxiety?" And fluoxetine is an anti-anxiety, antidepressant medication. It's been around for quite a while. It's a prescription medication, and prescription drugs are classified according to risk for causing birth defects or damage to a baby. And the categories by the Food and Drug Administration that oversees prescription medications are Category A, Category B, Category C, Category D, and Category X. Category A, prescription drugs are safe in pregnancy and will not have a problem with the baby. There are only a few Category A prescription drugs in existence. Category B means that it's probably safe in pregnancy and probably will not hurt a baby. Remember that we can't do research on pregnant women. We can't take 1,000 pregnant women, give them a drug, a prescription medicine, and see how the baby turns out, as you can imagine. So Category B drugs are women who took the drug, nevertheless, during pregnancy, delivered their baby. We looked at those babies, and they seem to be okay. So Category B is probably safe in pregnancy. Category C means we have no idea if it's going to increase birth defects and problems with the pregnancy and baby or not. Fluoxetine is Category C. Most psychiatric medications are Category C. So with my patients who are taking fluoxetine and similar anti-anxiety and antidepressant prescription medication, I ask them why they're taking it. And they say, well, sometimes they'll say, 5 years ago, my mom passed away and I got very anxious and very depressed and I went on medication. And while you never get over that, it's been 5 years and I don't really know if I need to be on it anymore. Or someone may say, I think it didn't make a difference. If I'm on it, not on it, I stopped it, didn't really notice any difference, went back on it. So that's probably someone who can wean off of the medication. But I've had patients who say, I stopped it and it was not a pretty scene. And that is somebody who needs to stay on it, in my opinion, because the potential benefit to the mom outweighs the unknown risk to the baby.
Okay. Yeah, and anything they need to hopefully find other ways to work with that during pregnancy if it is, dangerous and crosses the placenta. So there are ways that we have with acupuncture to work with anxiety that help. We also use guided imagery and meditation during the treatments, breathing techniques, things like that actually can help. We've had many patients who were doing IVF who were on anxiolytics who got off of them and successfully had a healthy pregnancy and didn't have that return, thank goodness, as we do treat during pregnancy as well. So safe things that are not going to, have side effects. That's what we focus on, safe and effective.
And I was hoping that you would say that, because if you didn't, I would have said it, that a lot of patients who do go for treatments with Dr. Duro, whether it's acupuncture or relaxation, biofeedback, different types of techniques for relaxation, anti-anxiety, often will help. The next question is, why is coffee harmful when I'm trying to conceive? And the answer is, in general, it's not. So I don't know why someone thought that it's harmful or who told this person that it's harmful. The caffeine issue has come up in pregnancy multiple times over the last 30 plus years that I've been in practice. Don't drink caffeine, drink it, it's fine. Don't drink it, it's fine. So my take on caffeine is that the equivalent of 2 cups of coffee a day, and I don't mean 2 of these cups, I mean a 6 ounce or even an 8 ounce cup, the equivalent of 2 cups of coffee a day, in my opinion, does not appear to be harmful, certainly for fertility and even in pregnancy. Excessive caffeine, when you start getting above that, has controversially been linked to miscarriage, although I'm not convinced of the data, but better safe than sorry. So I would not go excessive with the caffeine, but that's my take on caffeine. Dr. Duro, do you have any other thoughts on that, or is that pretty much in line with what you tell your patients?
Yeah, I mean, definitely we try to replace the coffee with greens or something that can be helpful for them so they don't rely on the coffee for energy. And also we tell them to still minimize that. If they do drink coffee, just like 1 cup a day usually, because a lot, being in Miami, they're talking about a cafecito or like a cortadito, strong.
Yeah, I'm not talking about those, right?
Yeah,
a cafecito, I'm not talking.
Right, I mean.
Bustelo.
A Bustelo, right. That has a lot more caffeine than perhaps just like a regular, cup of coffee. So
right.
Somebody's cup could be like this and somebody's could be like that. So so we work with just trying to substitute healthier options, more water in general as well, too, for them. So.
Great. Next question is in Spanish. I'm not going to even try to read it in Spanish, but I think I can translate it. And it says, what do we take into account when we select an embryo for transfer? Most of my patients today, the majority, 90% or more, are genetically testing embryos like I discussed at the beginning of our live event tonight. And so we generally have genetically normal embryos on these patients. When we select the embryo for transfer, we select the highest quality embryo. Having said that, we do have some patients who come to us from near and from very far away for family balancing. They don't have trouble conceiving, but they want to go through IVF and vitro fertilization with genetic testing of the embryos, because during the process, we know if it's a male or a female embryo. And if I have patients who have 2 boys and they want the girl, then we can select out the genetically normal, top quality female embryo for transfer. But the quality of the embryo is the single most important determinant of success, aside from the patient. If the patient is not in good clinical condition, you can take an AA perfect embryo, genetically normal, put it into someone who is high cholesterol, high inflammatory substances in the blood, which I measure, somebody who's very overweight or obese, which I tell my patients to work on before that embryo goes in. If the thyroid hormone is off by 1/10 of a point, it doubles the risk of miscarriage. Vitamin D levels are really important for the uterus to hold on to the pregnancy. The list goes on and on. I measure natural killer cell activity in my IVF patients and treat abnormal killer cells before the embryo goes in. I've had innumerable patients who've come to me from all over the world with failed embryo transfers. They're down to their last frozen embryo, and I test their natural killer cells, and they're not normal, and I treat it, and that last embryo goes in after I optimize their bodies for success, and they go on and deliver babies. So yeah, the embryo quality, the genetically normal, good quality embryo is really important, but more important than that, I have all of my patients go for fertility acupuncture before they go through IVF. I check mercury levels. I have multiple patients right now who eat fish, which is healthy. It's a good source of protein, with high mercury levels. Most fish have mercury, some more than others, some way more than others. And I measure mercury in the blood of my male and female patients, because high mercury in the man's blood will go to his sperm, will go to the embryo, and will potentially damage a baby's brain. I have a husband right now, a male partner, who had really high mercury, and we're putting him through a process where we bring the mercury levels down to normal. And normal should be under 10 or up to 10. His was 13, and we put him through the process. I'll see him tomorrow, and his level is now 8, which is normal. So nice. There are so many factors in the equation for success. Certainly working with someone like Dr. Duro, who's a reproductive acupuncture expert, is part of my formula for success, critically important.
So much of it is being a detective, you know, and figuring out what is the obstacles are there. I mean, there's so many with fertility that could happen. So right. It's great that you look for everything under the sun first before you go embark on something as big as IVF, you know.
The testing that I do goes above and beyond the norm, because my primary objective with our IVFMD patients is to level the playing field, normalize this, normalize that, so hopefully they can go home and naturally conceive. IVF is the last thing I want them to do. IUI, insemination, is towards the bottom of the list. So I try to restore natural fertility, acupuncture with you, herbs, different treatments, vitamin D if the level's low, thyroid if needed, and then they often go on and conceive naturally without having to jump through major hoops, which is the best, absolute best. The next question is also in Spanish, and I'm going to just translate it rather than read it. And it says, in your IVF center, when you choose the embryo to transfer, do you choose the embryo to transfer before you thaw the embryo? Or do you first thaw all the embryos and then pick the embryo? It's a really good question. And the answer is that we pick the embryo that we want to transfer before we thaw it. We don't thaw all the embryos or more than one embryo. We determine the grading, the quality, the morphology of the embryos before we froze them, and we have that all listed in the record. And when we go to thaw the embryo for embryo transfer, we thaw the genetically normal, best quality one. In our practice, there's a very small possibility it doesn't survive the freeze-thaw process. It's about 5% maybe in our practice. And if it does not survive, we go to then we thaw the next best embryo. Hopefully that answers that question. Good questions.
Yeah, very good.
I have more questions. Do you want me to keep going, or do you have something that you want to
Well, there's one question addressed to you also that we had received earlier that mentioned that it's directed towards you. It said, you mentioned previously you're not a fan of the ERA. Can you please explain why? What about cases in which an ERA was done and provided results that helped to change the next transfer to make it successful?
So like I say, I've been in practice for 31 years as a board certified fertility expert. Certainly ERA has not been around for 30 plus years. It's a more recent concept. It's an interesting concept for those who don't know what ERA is, as endometrial receptivity assay or analysis. It's a test to see if the uterine lining at the microscopic level is appropriate, hormonally prepared for implanting a pregnancy when we had previously frozen embryos, and now we're going to prepare the uterus with hormones to make it as perfect as possible for pregnancy, and at the right time we thaw and transfer that previously frozen embryo. The ERA does an analysis on the uterine lining under the microscope, if you will, to make sure that the hormone treatment that we gave is proper for optimal embryo implantation. I have seen more patients than I can talk about who had, and in order to do the ERA, there's a cost. You have to pay for it. You have to go through what's called a mock frozen embryo cycle. You have to take all of those hormones that we use for a frozen embryo transfer cycle, including weeks of injections. And then in our practice, I prepare the uterus for about 6 weeks with hormones and blood tests and ultrasounds to make sure everything is right for embryo transfer. And then what you do with an ERA is at the 6-week mark, instead of thawing and transferring the embryo, we take a biopsy, we put in a catheter and take out a little piece, more than a little piece of the inside of the uterus. It's called an endometrial biopsy. Send it to Egenomics, the laboratory that does the ERA, and wait for the report. The report either comes back saying, thumbs up, the hormone preparation you use is perfect as possible for embryo implantation success, or the report comes back saying you need to adjust it in this direction or that direction, a little more of this or a little less of that. And then they say just do that, make that change, and then move forward with treatment, and it should work. I've seen so many patients who did the ERA and it was not normal. These are patients who came to me from all these other IVF places throughout the country, and they, at that IVF facility, did the ERA, came back abnormal, the doctor made the adjustment, and they subsequently failed embryo transfer. And I've seen it over and over and over and over again. I had a patient who knew that I'm not a fan of it. This patient of mine, my own patient, had one frozen embryo, and she said, I want you to do the ERA before you put the embryo in. I said, I don't recommend it. She said, I know you don't, but I want to do it. So I did it. We have all the equipment to do the ERA in our IVFMD practice. We did it. It came out a little bit off. I made the adjustment, and she did not implant her embryo. There is a doctor in our practice who's a major fan of ERA, and we crunched his data, we crunched his numbers, and really did not see a significant increase in success rates having done the ERA and made the adjustments. So I like science. I don't like, we do it once and it doesn't work. You can't say it doesn't work. You only did it once or twice. But I like numbers. They're in one of the major journals that we read is called Fertility and Sterility. And, oh gosh, probably 6 months to a year back, there was an issue of fertility and sterility that was all about the uterus. The uterus is the black box of IVF. We look at the sperm, we look at the egg, we look at the embryo, but we have trouble looking inside a uterus. And it's really the so-called black box. It's the unknown of IVF. And so this issue, special issue of fertility and sterility was all about the uterus and the uterine environment for pregnancy, for IVF, and the statements that were made about ERA is that it's really not, in a lot of experts' opinions, it's really not ready for prime time. I know that I would be criticized to say that, but I say what I feel is true. I think it's a great concept. It's an interesting concept, but I personally don't think it's ready for prime time. So that's a kind of a long-winded answer for that short question.
Great. That's great to know.
When I do things to my patients, I want to do them with what I would consider to be significant benefit. And if I think you're going to spend your time 6 weeks, including injections and your money and discomfort of having this biopsy of the uterus for what I consider to be little to no benefit, I'll do it if you want to do it, knowing that, but I am not a fan of it.
That's great to know. We have so many questions. Like, guys, I love these questions. Remember, we are going to be doing these regularly on Wednesday nights. And we also want to let you know that if you go to YouTube or Facebook, I've been titling our questions as we go along so that if you miss something and you want to flip through the episode, you can actually go to the section that says ERA or embryo selection or any of that so that you can reference that, because we talk a lot about everything now. We also have another question that came in that basically said, I want to know what tests are performed on sperm before undergoing IVF. I hope he has time to answer this.
What tests are done on sperm before IVF? Generally, I do 2 tests, and one is a semen analysis, a sperm analysis. Basically, every practice, every doctor does a sperm analysis. And the 3 most important things that we look at in a sperm analysis are the sperm count, how much is there, the sperm movement, the motility, how is it swimming, and the sperm shape, which is called morphology. So a sperm analysis looks at multiple factors, but the 3 most important are the count, the motility, and the morphology, and those are important. Example, if the sperm count is 6, not 6 million, not 6,000, but 6, we're not going to have enough sperm with 6 to do in vitro fertilization if we get 10 eggs. You need at least 1 sperm for every egg. So the count's important. The movement is important, the motility, even for IVF, because I reviewed one of my patient's reports today, and he had 15% motility, normal's 40% or higher. And so most of his sperm were not moving. But the question is, why are they not moving? And in his case, they were dead, not sleeping, not kind of just sitting there wagging their tails, but they were dead. And that is of concern, and we need to go further into that. The shape of the sperm is important. If we're going to do IVF, we want to know that we have some normal shaped sperm, because we pick and choose a normal shaped sperm to put into a microneedle and inject into the egg to fertilize the egg and grow an embryo. But the sperm can look incredible on the outside, but what's really, at the end of the day, the most important thing is the DNA on the inside. Pregnancy, no matter whether it occurs naturally in the human body or in a dish, pregnancy is sperm DNA that mixes with egg DNA. And if the sperm DNA is fragmented, if it's broken, and you don't know it because you didn't do a sperm DNA fragmentation test, then you can take that sperm, put it in a needle. It looks beautiful on the outside. You inject the sperm with the fragmented DNA into the egg, and now the fragmented sperm DNA mixes with the egg DNA to make an embryo, half of which came from sperm DNA that's fragmented and broken, and those embryos often will crumble. They will often die as we're growing them to blastocysts. They often will not implant, or they will miscarry. So I look at not only sperm DNA fragmentation, but a test of sperm DNA functioning. How is the DNA working from the sperm with egg DNA in a laboratory setting? And so in our practice, we call that a male reproductive health panel. It looks at these different tests of the sperm DNA. And to me, it's a deal breaker. It's critically important, because even if you say, well, you're just going to take the sperm and put it in a needle and inject it in the egg and make an embryo, if the DNA is not in good shape in the sperm, this whole thing can fall apart. So I do a sperm analysis, and most importantly, I do sperm DNA fragmentation and function testing. These, if they're not normal, I have treatments for them. So I'm not a big fan of, hey, it's not normal, you're up the creek, sorry, too bad. I treat the man with certain treatments to repair the fragmented DNA before we do IVF, so that when we do IVF, we're going to have the absolute best possible outcome. Furthermore, we have a device in our IVF laboratory. If the sperm DNA is highly fragmented, I red flag the message to the embryologist, and we have a device that you put the sperm in one end, and basically when it comes out the other end, the device selects out the sperm with the least amount of DNA fragmentation. Really important. And I will tell you that that would be a potential reason why IVF fails in these other centers when I get the records from all these other places and the centers and the doctors are not looking at sperm DNA. Hope that helped to answer that question.
Very good. So the DNA fragmentation test, is that what you'd recommend?
Well, the laboratory that I have do the advanced testing on the sperm DNA looks at both fragmentation, and there's a functioning test called sperm DNA decondensation. And I look at all of that when I get the results because it has different implications. And these are treatable factors.
Very good. Oh, we could spend another Q&A going into the treatment, actually. But
all about sperm,
we're running low on time. So did you have any other questions that were submitted to you that you have over there that we didn't get to? Or?
Yeah, I have many.
Okay.
Let's see. Is there a product that you recommend for lack of cervical mucus? Cervical mucus, 100 years ago, used to be, 100 years ago in the fertility field, we really didn't have much to hang our hats on. And around the time of ovulation, a woman's cervix produces usually more mucus, and the mucus has to be abundant, and it has to be clear, not cloudy, and it has to be stretchy if you touch it and pull it, and so on and so on and so forth. And we really didn't have much more to go on than that. And so we looked at cervical mucus. We used to do postcoital tests where we would tell the couple at ovulation to have sexual intercourse, come in within 12 hours. We would take a sample of the cervical mucus and stretch it, look at it under a microscope, and do all things with cervical mucus.
Yes.
Yeah, that was described about 100 years ago by Dr. Huner. They called it the Huner test. And it's been abandoned now for a very, 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 very long time. Cervical mucus, turns out, is way less important than we ever thought. We have people who have no cervical mucus at ovulation, and 2 weeks later they walk in pregnant. We have people with the most amazing mucus, and they're not getting pregnant. So we don't look at cervical mucus. The old wives' tale about cervical mucus was that you take Robitussin to thin out your cervical mucus and make the mucus better, because they recommend Robitussin for a mucousy nose, but Robitussin does nothing for cervical mucus. So whoever asked the question about cervical mucus, put it aside, move on to other important factors for fertility success.
Good. We have 1 minute left, guys. So I'm sorry we couldn't get in all of your questions, but we did try. We also would want to encourage you guys to reach out to us. You could actually, Dr. Rosa, could you let them know how to find you on Instagram too? Because I know you're on the IVFMD.
Yeah, my Instagram is Dr, which is doctor, and then my first name and last name. I think it's DrScottroseff. They also call me the baby maker. So if you look for baby maker, you'll see me on Facebook and Instagram. I do DMs. You can private message me, direct message me. People do that quite frequently. I exist to help people create or expand their families. So I do, when I have free time, which I have very little of, I do try to answer questions. I can't be specific. I can't tell you what to do, because that means I'm dictating practice upon you, and that's illegal. but I can give you generalizations.
We appreciate all your help. It's been so informative. And also, you can find us on our websites, IVFMD.com and then FloridaCompleteWellness.com as well. Or you can go to the bio link and click on more information. We also have added our YouTube channel to our bio link on Instagram. So if you want to find all these Q&As, you can actually click on the first link within our bio link, which is our new YouTube. And I would really love it if you guys could subscribe, because we've been working on it. So hopefully we'll get every week that we do this, we'll just learn more and more. I can't wait for next time that we're here, next Wednesday, I believe. So we'll definitely let you guys know. And thank you guys for joining us. I really appreciate it. So Dr. Roseff, would you like to sign off with anything? Yeah.
Yeah, I'd just like to say thank you. Thanks for having me on your platforms. And I hope that it was informative for everybody. And I wish everybody success. Wish everyone the best.
Great.
Happy, healthy New Year.
Bye, guys. Bye, everyone.
Bye-bye.
Right.